for the best in Nevada,
Yeah, that and 15
right?
that and the $3 will get you a cup of coffee. Yes. So, but it's nice. It's a nice thing once in a while. So,
Right. So can you see the page? We're
yep,
good now?
there we go.
Okay. Okay. So
All right, we're good to go now.
basically, we will approach any chronic disease, regardless of what it is, any specialty, any system in the body. When we diagnose or treat, we need to consider those four pillars: redox, immune, metabolic, and regenerative. And I believe all of you, if I go through all your protocols, I can classify them under those four. And you will see that when we go through the articles. So let's get this thing out here. So comprehensive diagnostic assessment are essential in prevention and management of chronic diseases. The article explores the significance of evaluation. Got it out. Oops.
Yeah, I'll show you.
Can you show me? I'm not good with Apple. Oh, let's see, fix it, Dr. Joseph. I like Windows. There. No, that's not the one. This is the one, right?
It's on our screen.
Okay, then we have to. I'll get to it.
It's in your screen. You see it?
Yeah, we see it.
I don't see it. I don't know why. Okay, this one. See that one? Okay, good. Can you make it bigger?
It is based on redox, immune, metabolic, and regenerative status.
Right.
All right.
Right. Oh,
You, Dr. James, and Dr. Klatz. Right.
right. And if anybody wants to co-author with us, we're open for that too.
Okay. Abstract.
Right.
Need a
Do you see can you see that right now in the Word?
Yeah, I'm reading it.
Okay.
Comprehensive diagnostic assessments are essential for the prevention and management of chronic diseases.
Right.
This
Right.
article explores the significance of redox, immune, metabolic, and regenerative statuses in patients.
Okay. Can you see the article right now?
Yeah.
Okay. Good. Okay. Is it moving up and down?
No.
No. Are you seeing me moving the screen up and down or no?
No. It looks like you you're on a video. That's what it looked like.
Okay, let me see here because I think. Okay, right now, can you see it?
No. Now we got just everybody here.
Yeah, can you share? This is Apple computer. I mean, it's just it's weird. I don't know why they do it. Where is the thing? Zoom. Okay. I think that's the reason. Okay, that is it. Yeah. Yeah, do share. And then do this one. Yeah.
That's it.
Yeah, click on it. Okay, that's good. Okay.
And I'll get this out the way so
I will not be confused with it. Okay. So this is the abstract.
don't make that go away.
Comprehensive diagnostic assessment are essential in prevention and management of chronic disease. This article explores the significance of evaluating redox, metabolic, immune, regenerative status in the patient. By understanding these parameters, healthcare providers can develop personalized treatment plan that address the root cause of the chronic disease, ultimately improving patients' outcome. So what is chronic diseases such as cardiovascular diseases, diabetes, and cancers are leading cause of morbidity and mortality worldwide. Effective preventive and management of these conditions require thorough understanding of various physiological and biochemical parameters. This article aims to highlight the importance of comprehensive diagnostic assessment focusing on redox, immune, metabolic, regenerative status. By integrating this assessment into clinical practice, healthcare providers can offer more personalized and effective treatment. So when we manage chronic diseases, we need to find out the diagnosis first by using all the skill of assessing and interpreting the history and physical exam, and then we find out the right labs, and we do them, and then we come up with a diagnosis. But when we're not trying to even diagnose the patients, we need to consider those 4 pillars during the process of coming up with a diagnosis. And even when we try to treat it, we look, where is the pathology? Is it more redox? Is it more immune? Is it more metabolic? Let's say if the patient's metabolic, their sugar is high, cholesterol is high, thyroxine is imbalanced, sex hormone is imbalanced. This is metabolic, and you need to fix the metabolic. Let's say a patient has Parkinson's disease and he's shaking, and another patient has anti-NMDA receptor encephalopathy. Then this is more of immune than metabolic. Then you need to consider and focus on managing the immune system versus the metabolic. But eventually, after you fix the immune, you may consider and see other pillars. Let's say you balance the immune system, you give them naltrexone, or you give them those immune modulators that we're going to talk about it. But then the patient still, you need to look at, see if there's any metabolic deficiency, if there is any things that leads to oxidative stress. Let's say the patient has leaky gut, the patient has toxins, has infection. And so you need to screen all of this and start optimizing the patient's health based on those 4 pillars. And after you balance the immune system, after you balance the metabolic, after you fix the redox, then you say, okay, well, let's go ahead and fix his regenerative. So the priority of which you're going to fix first, it really depends on the patient's diagnosis, whether it is more metabolic. If it's primary metabolic, you fix the metabolic, and then you go through the other pillars. If it's primary immune disease, then you fix the immune, and then you go through other pillars. If it's primary redox, oxidative stress, like, for example, EMF induced brain fog, that's redox. Then you start thinking about how I can buffer the redox of the brain, and that definitely leads to decrease in inflammation. Maybe I need to put some immune modulation there, like naltrexone and others. And then maybe the patients also have other metabolic deficiency, vitamin D, sex hormone is not working, but there's a lot of crossing and a lot overlapping between those pillars. Let's say, for example, patient has an NMDA receptor encephalopathy, NMDA anti-antibody receptor, which is autoimmune disease, where they produce antibodies against the NMDA receptor, and the patient is shaking all over. And I think Dr. Yusuf relate to it because he has a case of that. So it is immune problem, and you can balance the immune system by using naltrexone and other immune modulators based on lymphocyte mapping, cytokine profile. You can know exactly where the immune system is polarized. But then you also think, okay, well, sex hormone, although it's metabolic, because you are restoring the metabolism of the body by giving sex hormones. Sex hormone is deficient, especially the progesterone. Yes, it is metabolic, but also progesterone, it is immune modulator. So when we recommend those patients to take intranasal progesterone here, we are for the purpose of modulating the immune system and decreasing the inflammation. Although we consider sex hormone as part of restoring the metabolism of the body, because there is a pandemic of progesterone deficiency, and it's being classified under metabolic, but the action is here. In this case, it's more of immune, because you're using it to decrease the inflammation of the brain. So, I mean, even if I classify all of this under those 4 categories, it's not solid classification. Those parameters and all those diagnostic things that inside those parameters or those panels are overlapped. So let's start with redox status assessment. And what is the purpose of assessing oxidative stress? Evaluate the cellular damage caused by oxidative stress. So when I'm trying to diagnose oxidative stress related diseases, yeah, you can directly measure the antioxidants, the glutathione, the ratio between reduced glutathione and oxidized glutathione, the NAD. Yeah, those are the antioxidants. And that gives you some understanding about the redox status of the patient, especially if they are decreased. But also you can measure the metabolites that is result from the damage that's caused by oxidative stress. Let's say the oxidative stress is damaging the DNA, so you will see in the urine oxyguanosine. I think that's one of the oxidative stress markers that we use in the urine, which is oxidized nucleotides. That will be indicative that the patient has oxidative stress. That's just one example. But the other option that we can do is, well, if you have damage in the endothelium that lines the blood vessels, it will lead to endothelial dysfunction, and endothelial dysfunction can manifest as decrease in the blood vessels compliance and their elasticity. They become more rigid. The more rigid they are, that is a reflection of the more damaged endothelium, which is endothelial dysfunction. That really relate, or it depends on how severe the endothelium is being damaged, which reflection of how much you have of oxidative stress. And so that compliance of the blood vessels, we can measure it by putting a little probe in the finger. It's an infrared camera. Squeeze the brachial artery and then squeeze the blood and then release it, and see the blood refill can be pictured by those infrared camera. And we can use by logarithm, knowing that is there the blood vessels compliance or flexibility is being compromised by oxidative stress. And you can see that they can interpretate the refilling of those capillaries at the finger by the heat that's coming up from the blood. Through a logarithm calculation and measuring the waves, they can know that the patient has mild or moderate or severe endothelial dysfunction. So that's one way of measuring the redox status, oxidative status or the redox status of the patient. And so if the endothelial dysfunction is severe, that means the patient could be also having problem with or have insulin resistance, right? Because that's a reflection of oxidative stress, too much of free radicals that can lead to blockage of the receptors of the insulin, and they don't be responsive, and you end up with insulin resistance. And there's a system for that, valuable, and it's built by insurance. And I like to have all the integrated doctors regardless where it comes from. Okay, so I put infection or chronic infection under oxidative stress. Why I didn't put it under immune? It can be, but I think it's better to say infection, Lyme disease, Epstein-Barr virus, they're all free radical generators. And that's the first thing. And then when they generate those abnormal pathological free radicals because of the toxin that's coming up from those infection bugs, then yes, eventually they will cause inflammation and they will disturb the immune system, and they will cause immune polarization. But I like to put it under redox as a redox, or oxidative stress generator. And also environmental toxins. I will put it under oxidative stress panel, because those heavy metals, and whether it is mercury or others, lead, they all are free radical generators, right? And that's how they affecting the body, and that's how they cause inflammation, and that's how they're causing damage. Eventually, everything will converge into redox. And that we're going to learn from that from the coming slides. So what about toxins? Again, toxins, there's water soluble, fat soluble. We consider mercury as a fat soluble toxins, and they can store in the fat tissue. All those petrochemicals, toxins that they can store in the fat tissue, and that's a problem. Those fat soluble toxins are more problematic than the water soluble toxins. Why? Because the fat soluble toxins, it's hard to get rid from it. What we have in detoxing out there, we have the activated charcoal, we have the EDTA, but all those ones, they can really do well with water soluble toxins. They're not doing well with fat soluble toxins. And before, we learned from Dr. Patel that we can do sauna and use the sweating to sweat out those fat soluble toxins. That's possible, use sauna and all that. So the fat soluble toxin can go out through the sweat, and then you wash out. that's one way of detoxing fat, but it's not that much effective than finding a chelation for fat-soluble toxins. Do we have that chelation? Yes. And recently we find out that, thank you for Dr. Klatz, cyclodextrin is that fat-soluble detox, and the only fat-soluble detox. It's a little chelation, yeah. It is a little sphere that looks like high-density lipoprotein. Inside is fat-soluble, outside is water-soluble. That's the cyclodextrin, and it works like a cargo track or a trash track that will collect all those fat-soluble toxins, the petrochemical, the xenoestrogens, name them, the mercury, anything that stores in the fat. Then it dumps it into the bile and the liver get rid from it. So cyclodextrin is the best way to detox the body from fat-soluble toxins. Also, cyclodextrin is the best way to deliver drugs. So that's why we put progesterone in it, progesterone-loaded cyclodextrin, intranasal, or oxytocin, and it definitely increased the efficacy, stability of the drugs. And I think now we have a solution to deliver the drug using cyclodextrin. That's why, you know, all those compounding pharmacy, we're asking them to start using cyclodextrin as a delivery method. And it delivered everything, IV, topical, ophthalmic, eye drops, everything. And it's the most safest delivery system that we know. Plus, in addition to delivering the drugs that you want to the target, you also are able to detox the body from fat-soluble toxins that's difficult to get rid from. So this toxin can accumulate in the body, contribute to, of course, those toxins, if they're inside the fat, they start released with time, and they aggravate any underlying chronic conditions or trigger any underlying chronic conditions. Especially when you start doing weight loss program and all those toxins will be released out in the blood, it may cause shutdown of the organs. That's the reason when we do GLP-1 or the glucagon-like peptides, I prefer that it will be loaded inside cyclodextrin or use cyclodextrin with it so that you can detox the fat-soluble toxins as they are being released during the process of the fat or weight loss. So the fat-soluble toxins are a significant concern. They can accumulate in the body fat tissue, pose various health risks, and those are the example of fat-soluble toxins. The pesticides that we know, heavy metals, some of them lead and mercury, environmental pollutants, all those names which is difficult to pronounce, dioxins, and the byproducts of industrial process, and all those organophosphorus, and name it. The polychlorinated biphenyls, and all those fat-soluble toxins, we can get rid from them. Plastics as well, we can get rid from it using cyclodextrin, and that's a good thing. Preservative and food additives also that can be fat-soluble toxins as well, which we have it a lot in our food chain, especially here in the United States versus other countries. And then there's lots of pharmaceuticals that can be stored in the fat tissue as well, that they're fat-soluble toxins. It's good that we have something to get rid from them. And so cyclodextrin will be the answer. And those cyclodextrin will collect those fat-soluble toxins, dump in the liver, the bile, and then the bile will get rid from it through the feces most of the time. I mean, we can get some rid from it through sweat as well, some of them from the urine, but mostly it's coming out from the bile. Mycotoxin testing. So mycotoxin, I put it under redox assessment because there are free radical generators. And definitely we need to screen for mycotoxins. And we're not going to do all the screening for every patient. Based on history and physical exam, that would determine exactly the lab that you're gonna do. Because I'm against those people who are candy shop, just screen everybody with fungus, screen everybody with heavy metals, just give them detox. This is candy shop clinics. I'm against it. I like to have it more precise based on physical exam, based on comprehensive history physical exam. Then I determine exactly what the lab needs to be done so it can be efficient and effective, not just blindly assuming everybody is toxins and and let's just go ahead and detoxing them. Well, if there's a history that indicate that the patients may be having toxins, then why not? But if there is none indication, let's prioritize the treatment based on what the patient is complaining from, and then go step by step. And if we end up doing detox at the end of the road, that's fine, but not in the beginning of managing the patient. Because we need to be more efficient and effective in our management, not just, everybody, like those people are opening detox centers, and everybody comes in, okay, go ahead, detox, without being even checked, without being diagnosed, without being seen. I think that's not what we supposed to do as doctors. And we know mycotoxins is very, very difficult to get rid from it. We don't have any detox for mycotoxins up to now, except recently we come up with cyclodextrin, and cyclodextrin, it is the only chelation detox for mycotoxin. Okay, what about spike protein? Yeah, definitely. Whether it's coming from the vaccine or it's coming from the infection itself, we need to consider screening that, because I think 99% of the whole world populations got infected or got vaccine. And, you put that in your equation when you are doing the history physical exam. And if you see that it's something that you may consider it, then you start screening for it. And there is testing that we are working on developing, hopefully, for the spike protein antigen. We know that it's causing what we call the spikeopathy, and it contributes to the health issues. And how we can detox it? Again, cyclodextrin. Cyclodextrin is the way that we can detox spike protein, and you can search it and you can see articles about cyclodextrin as a way to detox the body. What else? The other thing is that pharmacogenetic testing. Why I put it under redox status? Because if patients is taking medication and this medication is not metabolized in the body for that specific person because of genetic SNPs, then you end up that those metabolites from these drugs will be free radical generators, and it can lead to side effects. And so choosing the right drug, the right pharmaceutical, we have many choices. Let's say they have same mechanism of action, but they are different in their pharmacokinetics and the way that how they metabolize. Then we can choose the right drug among those 5 choices, and that is able to or be metabolized by that person, because the genetic SNPs is not causing a problem in metabolizing that drug and leading to metabolites that will generate free radicals. We call them free radical generators. So that's the reason pharmacogenetics would help us to choose the right drug. Any drug, whether it is cardiovascular drugs that we use for cardiovascular diseases, especially the antihypertensive drugs, we can choose the right among all those different brands based on the pharmacogenetics. We can find out exactly which cancer drug that is more effective for that cancer, or that does not have abnormal metabolism for that specific person due to the genetic SNP. So it just helps us to personalize the medicine and minimize the side effects, especially when it comes into narcotics. We have a variety of different narcotics. And when we do the rotation in narcotics, because I did pain management for a while, sometimes you do a rotation and you end up with a narcotic that has a lot of side effects because the body has a problem with metabolizing that specific narcotic. So when we do a rotation of narcotics and we don't want a patient end up in the ICU, then you can do pharmacogenetics and making sure that the drug the narcotic that you're rotating to, it's metabolized in the body safely without generating free radical generator metabolites. So pharmacogenetics is something good to be employed in the clinics. The other thing, as I said, in the theo function test, we talked about it, which is assessing the redox status, vascular health, and monitor the treatment effects of chronic disease. Definitely the theo function test. In addition, it helps us to assess that the patient has oxidative stress. And not just that, it tells us exactly, some people, they have oxidative stress, but it's subclinical. It's not manifested. It's in the gray area between the clinical, which is the red area, and between the health optimized area or zone, which is the green area. So we can know, even if they are subclinical, not manifesting anything, that they have oxidative stress. Throw endothelial function test because there's a score for it. Even the subclinical oxidative stress that's not manifested, you can see it there, and they can be scored. And knowing that there is underlying oxidative stress, but it's not manifested, but it is leading to manifestation, and you become clinical sick. The patient becomes. We can stop that from moving to that direction by finding exactly what's the source of this free radical. It could be sex hormone deficiency. It could be mycotoxins. It could be leaky gut. It could be the drug the patient is taking. It could be rheumatoid arthritis. It could be psoriasis, whatever it is. Then we can specifically determine what it is. But to determine that there is oxidative stress, generally, not specific, and in a more sensitive way, we can use endothelial function test. Okay, so now the score, let's say it's 60, and the patient is not manifested, so it doesn't complain from anything. So it's subclinical. So I will look for what the source of those free radical is. Maybe because patient has progesterone deficiency or sex hormone imbalance. Maybe because patient has leaky gut or toxin. Based on histophysical exam, we will find out exactly where we need to go in the lab side and finding out where the source of those free radicals and start optimizing the body. When you're optimizing and treating the body, let's say patient has progesterone deficiency or vitamin D deficiency, and you start giving them all these treatments, and you start giving them all the supplement, everything. Okay, and how do you know those treatment that you did, ozone, whatever, exosomes, how do you know it's working, right? Then you can see the score of the endothelial function test is proved after 2 months or 3 months of the treatment. So having endothelial function test in your clinic, it is something that I would recommend every integrative doctors to have. It's like a stethoscope for doctors. You know, mainstream medicine, they have stethoscope. This is one of because those are sensors in our bodies. The temperature is the sensors that we use to see, to feed, to find out the patient has inflammation, infection. Blood pressure, it could be a sensor too, and we use the sphygmomanometer to measure the blood pressure. Those are vital signs. An extension of that, there is also endothelial dysfunction, because the endothelial cells is the most sensitive tissue to oxidative stress and inflammation. And so it's a sensor for any imbalance or disturbance, oxidative stress in the body. It's the same thing that you do when we are trying to fix the car and scan the car. We put that little plug under the dash, and then that screens the car mechanics, right? I mean, those are recent car, all of them, they have a diagnostic. They have sensors. Endothelial cells are the most sensitive tissue for oxidative stress, and we have that system to diagnose and assess the endothelial function, which is assessing the oxidative stress and inflammation. What other sensors we have? We have autonomic nervous system. They get sick too when there's oxidative stress, and they don't fire normally. Either they're firing too much, or they fire, but it's not in the right time. Let's say patient has autonomic neuropathy, and when they stand up, they feel dizzy or brain fog. That's because they have autonomic neuropathy, and the sympathetic is not firing up to increase the heart rate, to increase the blood flow to the brain. And so now we know there's autonomic neuropathy here. And how we can know that? Well, if there's autonomic neuropathy, then the heart variability will become abnormal. Because normally when we stand up, your heart rate will go up. But if you have autonomic nervous system or neuropathy, your heart will not go up, and then you don't have enough blood in the brain, and you end up with a foggy brain and imbalance or tiredness or fatigue. And so that could be because of autonomic neuropathy, and autonomic neuropathy is due to the oxidative stress. Maybe it's because of rheumatoid arthritis. Maybe it's because of leaky gut. Maybe because of diabetic patient. Maybe because of the toxins. Maybe because of mycotoxin. We don't know. We need to specifically know. And if we manage that, you can see the neuropathy is improved. You can see the heart variability will improve, because when we stand up, the heart rate goes up. When we sit down, normally the heart rate will go down because your parasympathetic goes up, right? When we relax, we're supposed to having a parasympathetic to be active and fall asleep. Some people have difficulty sleeping. Why? Because they cannot switch from sympathetic to parasympathetic. Why? Because they have neuropathy. Why? Because they have oxidative stress. And so we need to screen those sources of free radicals. And once we screen them, we find out where they came from, then we start managing them. We can see the heart variability will improve. You know, the flare-ups of rheumatoid arthritis and psoriasis you can be seen through endothelial dysfunction. Big Pharma, they use this system to monitor the efficacy of Big Pharma product, not just integrative products. So what's that mean? If patient is taking exosomes and we don't know the exosome works or not, how we do it? Well, check the endothelial function and heart variability before you give them exosomes. If their score, let's say 70, and you give them exosomes, and after 3 months or 2 months, or maybe after immediately, you test it and you see the score goes up to 75. And after 1 month of twice a week of treatment of IV, it goes up to 80. Then we can tell the patient, you start with 60, for example, and you end up with 80 because of those exosomes. And those exosomes do work. And so as a doctor, you can even validate any company out there comes out with drugs or supplement or exosomes and tells you, my system works. Okay, well, let's go ahead and test it. We have the system that the Big Pharma use to monitor the efficacy of any treatments, whether it's Big Pharma or integrative, and we can find out. In 7 minutes, you can know. So I want everybody to have the system. I don't care about where you're getting the system, but endothelial function test is billed by insurance. It's approved by FDA. Autonomic nervous system and pseudomotor, all of this will help to monitor the efficacy of treatment. And it just gives you a tool like a stethoscope to monitor the efficacy of your treatment. That any other things will not be sensitive as endothelial function test. We don't have the heart, the blood pressure, the temperature, all those vital signs. And ECG does not show they're not sensitive, especially when it comes into oxidative stress, than endothelial function and autonomic nervous system. They're not specific. Very important. You still need to find out exactly what source of the free radicals or inflammation is during the lab, but at least it tells you where the patient's redox status or inflammatory status is. Okay, so the purpose here is to assess redox status, vascular health, and monitor the treatment efficacy of chronic diseases. That's very important. Monitor the treatment efficacy of chronic disease. Put that many lines under that. Clinical relevance. Endothelial dysfunction is an early indicator of pathological oxidative stress, such as, one example is cardiovascular, but it's not just for cardiovascular. It does help us to prevent cardiovascular event from happening, which is the stroke and angina and all that, but it's not. It's for any oxidative stress out there. It's good for rheumatoid arthritis. It's good for Parkinson. It's good for Alzheimer. It's good for the leaky gut. It's good for, name it. Any inflammatory disease, you can use endothelial function test to monitor the efficacy of the treatment. You can use cohort study to come up with a study to evaluate even the system that you're doing, your treatment system. Is it working or not? Autonomic nervous system is another way, because the autonomic nervous system, the unmyelinated fibers of autonomic system are very sensitive to pathological free radicals, and they get sick, whether they become dominant sympathetic, and when you stand up, they don't fire normally when you stand up, and increasing the heart rate, and so that you end up feeling, brain fog, dizzy, depending how severe it is. And then when you sit down, you're supposed to, sympathetic goes down, and parasympathetic will lay down, but the parasympathetic is not working. Why? Because those unmyelinated fibers are being oxidized, rusted by the oxidative stress, by the inflammation. Once you improve the inflammation, yes, this will reverse, and you can see the heart variability, it normalizes, right? You don't want to have a heart variability fixed like this. You need to go up and down. That's healthy, right? Heart rate up and down. If the heart rate is fixed, that's not healthy. If the heart rate is all the time 75, that's not healthy. That means sympathetic parasympathetic is not working. Now you need to have that normal variability. Okay, so the purpose is to evaluate autonomic nervous system function, which assess the redox status, which monitor the treatment effects of chronic disease. That is very important. Not for cardiovascular disease only, because the company who is selling this system, they thought it's only for cardiovascular, and they're selling it for, no, it's for all chronic disease out there. Now, so the heart rate variability is a marker for autonomic balance and also for oxidative stress-related disease, all of them. Pseudomotor testing. In pseudomotor testing, It's a little metallic plate to put your feet on, and it tells you about the conductancy of the sweat. It's conductive or not. Is electricity pass through the sweat or not? If the sweat does not have much of salt, it will not conduct enough. And the system will tell that the sweat is not conducting electricity because there's no salt there. More salt, more conduction, right? So think about it. If you have oxidative stress and inflammation, and your unmyelinated fibers in your foot, which we have two of them, we have the sympathetic that supply the sweat glands, and also we have the C fibers of the pain, which supplies your feet, right? Okay, both are unmyelinated. But what we're measuring the function of the sympathetic, because if the sympathetic fibers are not firing well because they're being damaged because of oxidative stress, because they're unmyelinated fibers, they're not myelinated. Unmyelinated fibers are very sensitive. They don't have the envelope, they don't have the sheet. And so they get damaged and they don't fire. And you don't have sympathetic enough to the blood vessels of the sweat gland. Now, very important, sympathetic in the blood vessels of the sweat glands, they are not epinephrine. They are acetylcholine. And they are causing vasodilation through increasing the nitric oxide. So sympathetic, when it fires in the sweat gland, it's causing vasodilation, not vasoconstriction. It increases the blood flow in the sweat, and then you sweat. The blood, it's like kidney. The blood will go through the filter of the sweat, and then it goes through the duct, and then the duct will start absorbing the salt. If you have too much of sweat going, you don't have much chance of absorbing the salt in, like the kidney. Then you would have a sweat that has enough of salt, then the conductancy is good. That's mean your sympathetic fibers is working. That's mean those myelinated fibers in the feet is working, including the C fibers, which means that you don't have neuropathy. But if your sympathetic is not working, and you don't have much of vasodilation in the sweat glands, you don't have much of sweat going there because you don't have fluid going to the sweat glands, and then you don't have much, then all the salt is going to be reabsorbed. What will happen to the sweat that's coming out? It's going to be very diluted. So when you pass electricity, when you put your feet on the metal and it's past electricity, it's going to be difficult to pass because the sweat is very diluted, which means that there is sympathetic neuropathy. Indirectly means that if the sympathetic is being damaged and it's unmyelinated, then your C fibers is unmyelinated, then this patient has neuropathy. So we can use it also to assist the patient with neuropathy. So when you start treating the neuropathy with all the things that we do, the nitric oxide, the thiols, the exosomes, name it, then you can, and you're improving the function and the health, and you're reducing the redox and inflammation, and those sympathetic start firing. The sweat is not working, and then you expect also your C fibers to become healthy again, and you don't feel neuropathy again, and neuropathy will be reversed. So it's a good way to assess not just oxidative stress and the autonomic nervous system, but also you can assess the sympathetic, the C fibers, and you can use it to diagnose neuropathy. So clinical usefulness for pseudomotor is diagnose autonomic neuropathy, oxidative stress-related disease, plus neuropathy, which is for pain neuropathy, or C fibers neuropathy. So the pain doctors can use it as a way to assess pain neuropathy. Okay, then the same system, which is a good thing, it does have the ABI, so that you can know if there's any blood vessel narrowing. And also it has the ability to assess your the ratio between fat and muscle mass. How? Well, if you have too much of fat and you try to pass electricity, for example, from the hands to the feet, right? If you have too much of fat, you have resistance. And so the system with logarithm will tell you this patient has too much of fat. Okay, but if the electricity will pass through the body from the hands to the feet, then they have less fat and they have more muscles and bones. And then with the logarithm, this system will tell you about your fat mass index or fat muscle ratio. And that's something good, especially when you start doing the weight loss. And yes, obesity is part of oxidative stress. If you have oxidative stress, you will have more fat in your tissue, because oxidative stress can lead to cortisones, moving your pathway of steroids to cortisones. It can lead to moving your 6 hormone to estrogens, and both the cortisol and and estrogens leads to buildup of the fat. Also, the inflammation in the fat tissue, when you have oxidative stress, those fat tissue cannot burn the fat because those enzymes will be blocked by oxidative stress. Your mitochondria will be blocked and become sick, so you cannot burn the fat. And so when you manage weight loss, you also need to consider buffering the redox, but work on the redox, works on the inflammation, right? Work on the leaky gut, work on anything that leads to inflammation of the body, work on the mycotoxin could be, work on heavy metals, because all of this can lead to oxidative stress and prevent the fat from being shrink, because it will lead to mitochondrial pathy or sickness of the mitochondria, where the patient cannot burn those fat. Then after that, we move on to assessing the immune status of the patient. That's very important. This is the new field of medicine. There is only one lab does it. I don't want to mention the name because it's a CME, but they do cytokine profile lymphocyte mapping. And it's very important to go and learn about the immune system status of the patient, whether it's if the patient is Th1 polarized or Th2 polarized, Th17 polarized, and then how you modulate it, not suppress it, how you move it from, how you inhibit the Th17 components and Th1 if it's overactive, without suppressing the Th2. When you suppress this, then it moves the immune system to Th2. So how you modulate, not suppressing the whole immune system, okay? If it's overactive, one of those components, yeah, I want to inhibit it. But I don't want to have the whole immune system and put the patient at risk of having cancer or infection. So that's the difference between immune modulation and immune suppression. Here, in our integrative approach, we do immune modulation. We find out which one the patient has too much. Is it Th1, Th17, or Th2? Oh, the patient has rheumatoid arthritis, so they have Th1 and Th17 according to lymphocyte mapping. Then let's find out what will inhibit the Th17 and Th1. Or patient has allergy and they have too much of Th2 and Th17. Let's find out what inhibits the Th2 and Th17. We don't want to inhibit the Th1 with cortisone, which inhibits all of them. We want to inhibit the one that's being overactive. Which components of your immune system is overactive? And we do that with lymphocyte mapping, cytokine profile. We determine whether it's Th1 dominant immune disease or Th2 or Th17. And sometimes they are both Th17 and Th1 dominant. Or in allergy, it's Th2 and Th17 dominance. Most of the time, autoimmune disease, they have the Th17 overactive. And so that's why Dr. William likes to use naltrexone. It works for both. For Th1 dominant disease and Th2 dominant disease. Why? Because both of them, they have too much of Th17, and naltrexone is a very good inhibitor of Th17, including ivermectin. They're a very good inhibitor of Th17, including methylene blue. So you can see they're working in both sides of the aisle. When I try to manage cancer, cancer is very tricky. They secrete chemicals to polarize the immune system away from Th1 and cytotoxic T cells. They're moving it to Th2 and Th17, right? That's a cancer because cytotoxic T cells kills the cancer. Th2 and Th17 does not, because Th17 gives you neutrophils. Neutrophils cannot do nothing to the cancer. And Th2, what they give, basophils and mast cells, well, that's not gonna, actually that's gonna help the cancer to grow. What I need in cancer is Th1 and cytotoxic T cells, right? I need those guys to go and battle the cancer and poke holes in the cancer and blow them up, right? Shooting them with antibodies will not work, all right? And so we need to polarize the immune system in cancer into Th1. So what I need, anything that polarizes the immune to Th1 is good for cancer. Anything that inhibits the Th17 is good for cancer. That's why we use naltrexone. If you see the lecture of Dr. William Bell, he say, well, even the cancer, I give naltrexone and it works. Yeah, because you're inhibiting Th17, which is overactive in cancer, right? And you can give also antihistamine and things that inhibit the Th2 for cancer, right? The Benadryl and antihistamine will help the cancer. Why? Because you're inhibiting Th2 and you're moving the immune system to Th1. What about thymosin alpha? Oh, that's good, thymosin alpha, because it polarizes the immune system Th1. Oh, what about thymosin beta? No, thymosin beta, don't give it to the patient with cancer. Why? Because it will stimulate the movement of the immune system to Treg and Th2. You don't want that. Yeah, thymosin beta good for rheumatoid arthritis because you want to inhibit the Th1 and Th17, but don't give thymosin beta to patient with cancer. That's the reason when we're doing peptides, it's very important to know those drugs, where they polarize the immune system, because sometimes you end up giving a peptide that will make the cancer worse. Why? Because lack of understanding of the mechanism of action of peptides and how they polarize the immune system and how they modulate the immune system. So when we do the CBC, it's better to do differential, not CBC only, because a differential CBC will tell you, okay, there's a lot of neutrophils. Well, if you do too much of neutrophils, what's that mean? That's mean you have too much of Th17. If you have too much of basophils and mast cells, oh, that's mean Th2 dominant. If you have too much of lymphocytosis, that's more of Th1. So it gives you some picture about what's going on. And so if it's too much of Th1, that's mean either the patient has in cancer or viral infection. If it's too much of Th17, this could be fungus infection, right? Or it could be fungus infection. If it's too much of Th2, it could be worm, or it could be allergies. So it helps us to really, just by CBC and differential, the differential part helps us to know whether this is bacterial infection or viral infection, because bacterial infection, most of the time you will see Th17 and you see neutrophils high. While viral infection, you see lymphocytosis, cytotoxic T cells, right? Cancer, lymphocytosis, is Th1 cytotoxic T cells. The only thing tricky is the virus called COVID virus. COVID virus is supposed we will have Th1 high. But the fact is that we find out those patients has neutrophilia and they have virus. They have Th17. That's because the virus is fooling the immune system, and they have a spike protein that inhibit the ACE2. When you inhibit the ACE2, you are increasing the signals of the what we call it, the angiotensin type 1 receptor signaling, and that leads to polarization of the immune system away from Th1 into Th17 and Th2. And then you will see the patient has neutrophilia, but it's viral infection or neutrophilia. Well, a lot of doctors got confused. They thought it's bacteria. But that's the virus is fooling around the immune system and saying, it's bacteria, but it's the virus. And definitely that leads the virus to start proliferating and differentiating inside those cells, because nothing is going to kill those cells. You need cytotoxic T cells. But because of the spike protein acting with interfering, hijacking renin-angiotensin system and blocking the ACE2, it leads to activation of renin-angiotensin type 1 signaling that leads to polarization of the immune system away from cytotoxic T cells. It's same like cancer, the COVID. And those spike protein are very dangerous, because it definitely helps even the vaccine. And instead of having a memory of cytotoxic T cells to clear the cells that's been infected, they polarize the immune system away from it. And that's the reason those viruses inside the cells, they're mutating and emerging, and new strains is coming up because nothing is clearing them up. So let's go to inflammatory markers. Yes, if patients they have inflammation, you need to do the basic inflammatory markers. And definitely, you can do cytokine profile. Cytokine profile also helped me to determine where the immune system is heading. If interleukin 6 is high, that's Th17. If the interferon gamma is high and interleukin 12 is high, that's Th1. If the interleukin 4 is high, that is more of Th2, and that's more allergy. So through the cytokine profile, I can know where the immune system is polarized, and then I can make a strategy to balance the immune system. Let's say you have rheumatoid arthritis and you have Th1 overactive and Th17, and the cytokines, you will see is high interleukin 6, interferon gamma is high, interleukin 12 is high. Okay, so now we know, through the cytokines, so lymphocyte mapping is all directing, this is Th1 dominant with Th17. Then what we will do? Well, let's look for things that inhibit Th17 only, right? Th17, and also you inhibit the Th1. Because if you inhibit Th1 only in those diseases, it's not going to be enough. You need to inhibit the Th17 as well, because they did it for multiple sclerosis. And they came up with antibodies that inhibit the interferon gamma, and the patients still have problems. And because the Th17 is not being inhibited. So let's figure out if there's any big pharma drugs that inhibit the Th1 and Th17, we can use it in low dose, or we can use those integrative therapies and supplements that we know that they inhibit the Th17, like Methylene Blue, ivermectin, they inhibit the Th17, naltrexone, name it. There's many things, and Dr. William Bill knows them a lot. And then Th1, what will be the good one? Thymosin beta will be good to inhibit the Th1. What else that inhibit the Th1? Remember that? No, the one that we recommend to Dr. Sylvan. I forgot the name of it, but it's a supplement that's yellow in color. They use it as a photosensitizers and they inhibit the CD8, but I forgot the name of it. So maybe, after I finish this, my brain will come up and know it. But you remember that thing we give it?
Wasn't one that I was familiar with.
The one that supplement we give and say to Dr. Sylvan to try it. I forgot the name of it, but there's supplements that specifically inhibit the Th17 as well. But I will use tyrosine alpha, the BBC 157, all those things do inhibit the Th17. Is good for rheumatoid arthritis, but there's many other drugs as well does that. Or supplements if you're looking for supplement. Or you're doing exosomes. Does the exosomes helps to balance the immune system as well? Or you want to use the big pharma drugs, especially if they're injectable, you can use lower dose by loading them inside platelets, nanoparticle, or cyclodextrin. That's another topic. Okay. Lymphocyte mapping and cytokine profile, we talked about it. It's very important to map your immune system, our patient's immune system, to know where the immune system is being polarized, and then work on modulating the immune system. If you give cortisone all the time and you suppress the whole thing, like what we do most of the time, then you end up, the patient has higher risk of having cancer infection. I think it's better to look for immune modulators, right? That specifically inhibit whatever it's active from all those components.
I want to ask a quick question.
Yeah, go ahead.
Patients that have high levels of cortisol, they've got multiple toxicities. I think that's a good example of when you would definitely not want to put them on a steroid because they're not responding. It's almost like their steroid receptors are already saturated and it's just triggering more inflammation. And that's when I realized that there was a place for immune modulation. How do you get the inflammation down when somebody has a chronically high cortisol due to some sort of, I would say their neuroendocrine, they're having neuroendocrine dysfunction, lots of brain inflammation, maybe even EMF toxicity, post-COVID type symptoms. And they're almost having too much adrenal stimulation, or they're producing too much cortisol. So that's when I realized that steroids don't even work because they're already, the receptors for the steroids are already saturated, and all it's doing is producing more, perhaps more side effects, but it's not reducing the inflammation. That's where modulating and using peptides has a place. And then if you're going to modulate, then that's why it's important to understand this language that takes time to learn, by the way. I mean, this is my sensei right here. He's the sensei. He's the one. And it took me a long time to learn this language, but that's why I got into this was because I realized I just did not know what I was doing. I didn't have a language to describe why I would do whatever I'm doing. And this idea of shooting in the dark suddenly became obvious and something I didn't want to do. But, all I can say, if you don't understand all of this stuff, I mean, even I'm taking notes. And I've been doing this for 4 years with Dr. Halasa. But this language is learnable, but this is the language that is what I believe is, if you can speak this language, nobody's going to scrutinize you in the medical community, the mainstream.
Well, then you look for another immune modulators, like things that he brought on the table, which is many of them. Clotho is one. Other thing that he did, amloxanox is a very effective immune modulators to really navigate this hyperactive, Th1 or Th17. The one
that one is across all the board. So
right,
if you're
including
not sure,
Th2,
if you're not sure, it's a mild to moderate modulator, but it's modulating Th1, Th2, and Th17,
right,
and it's a mast cell stabilizer.
Right.
I found that one was actually I had results with a patient with I would say having tremors secondary to autoimmune, and this is becoming more common, autoimmunity to various receptors in the brain that can look like Parkinson's, but it's an autoimmunity to very specific nervous pathways.
And you don't worry about,
And having a patient actually walking up and down the stairs without assistance, when they couldn't do that because they couldn't stabilize, they didn't feel steady on their feet because of overexpression of certain pathways in their brain and less of others, without making it too
right, let
complicated.
me add something. People say, well, if you suppress the whole immune system, you put the risk of patient of having cancer and infection.
Well,
That's not the case for amloxanox, because amloxanox is anti-cancer itself.
And also it's not suppressing, it's
Right.
it's modulating.
It's modulating, it's not causing the suppression to the point where it's been immune compromised.
It's gentle.
But the other thing is that does smart with amloxanox. It's anti-cancer itself. So any drug that modulates the immune system at the same time it's anti-cancer, it's more safer, right? Steroids does not do that. Suppress the immune system, but it does not have anti-cancer. In fact, it squeezes the immune system more to Th17 and Th1. That's what is in favor in the cancer model sometimes.
Dr. Halasa, how can you say it is anti-cancer? It does modulate Th1, Th17, but
Right, but at the same time, it kills the
doesn't
cancer.
have apoptosis.
Right, but at the same time, it kills the cancer.
So
that's the good thing about amloxanox. Same time,
What do you mean by kills the cancer?
what is that?
What does it mean that it kills the cancer?
It does have anti-cancer effect.
It turns on AMPK.
Right. You
While
got my point?
Yes, turning
No.
on AMPK while but it's not.
I mean,
suppressing.
it does immunomodulation, and I agree with that. It does Th1, and through that it increases the apoptotic activity. But anti-cancer,
It
when
does
we-
activate the
anti-cancer,
AMPK
it's not
and it
that
doesn't have a
doesn't destroy
mTOR.
the DNA.
Right.
It doesn't break the DNA strands or single
No,
DNA.
it inhabits the mTOR.
So
And-
we cannot say it kills the cancer. We can
Well,
say it immunomodulates the cancer.
Right. It works on the immune, but also the cancer itself. If you inhabit the mTOR and activate the AMPK.
Cancer protected would be a better.
Well, yeah, but
phrase.
it does have some, it activates the AMPK and inhibit the mTOR itself. It does help in the cancer itself. And I'll send you articles about amloxanox as an anti-cancer.
Okay.
Okay, not just that, hypericin. It's another supplement that I just reminded. It inhibits the CD8, and we can use it for rheumatoid arthritis. And at the same time, hypericin is anti-cancer as well. It inhibits the mTOR and activates the AMPK. So that's a good thing. If the drug does two things, it's more safer than just suppressing the immune system, allowing the cancer to flourish. But if it kills the cancer, that's a good thing. Let's go ahead to give another example. All the antifungal drugs, most of them do kill the fungus, but at the same time, they inhibit the Th17, those antifungal drugs. That's one of the mechanisms that we use antifungal drugs to kill cancer and boost the immune system, because they inhibit the Th17. But there's other mechanisms that antifungal drugs can kill the cancer directly. But when we do it for antifungal, they're killing the fungus, but also they're putting the hyperinflammation that's caused by the toxins of the fungus down, which is Th17 inhibitor. So what's our antifungal that we know? Astrazole, what's the name of them? What's the common antifungal?
Fluconazole.
Conazole, yes. So conazole is a
Fluconazole,
Th17 inhibitor and kills the fungus. Tetracycline, same thing. It inhibits the Th17 and kills the bacteria of the Lyme, which is something that we want to decrease the inflammation and kill the bug. That's why we use those drugs, because of their double action. Again, I put chronic infection. I think Dr. Patel, she's the master of all of these things, because she is I can consider her the mother of chronic disease prevention management. She has three big books. I went to her office. She has like 2 big stack of books of chronic disease prevention and management. So she's the mother of chronic disease prevention and management, by the way. And infection, I put infection under redox status, not immune, because I see the infection is a source of free radical. They are free radical generators. But definitely they will lead to inflammation and disturb the immune system. But I'd like to put it under redox.
I think it crossover. It crossover.
It is crossover, yes.
It-
I
it
told you
does-
those.
It's
Yeah.
the immune system, somehow it does not defend it. So one gets the infection, and then that is the after effect of infection is the redox. So even though you like to be under the lot of damage is done by the oxidative stress, but how one gets the infection, it overwhelms the immune system, cannot fight it, and then one gets the infection. So I think to put the immune system aside and put the redox on the top, I'm not too sure whether that's a correct
No,
way of
no. Those
looking
four
at it.
pillars are not on top of each other. They are overlap, as I said,
That's right.
to each other. But I just put it under the redoxin state of the immune because those infection, they release
Right.
chemicals
But most of the
free
damage is done
radical
by
are
it.
free radical generators. And because when we're trying to manage chronic diseases, we want to find all the leakage of the free radicals, whether they are toxins. The common thing between toxins, heavy metals, and infection, both of them are free radical generators. And then when they generate free radicals, the free radical itself activate all this immune system and lead to inflammation. But definitely, they're why they are polarizing immune system Th17. The other one is polarizing to Th1. This has to do with the macrophages when they eat the bacteria and taste it. It polarized the immune system to Th17 because the macrophage is engineered with knowing that this is bacteria and lead to release of those cytokines that polarize the immune system into Th17. When they eat the virus, they taste it, and they've been engineered to polarize the immune system by releasing cytokines that leads to Th1. Except it's being fooled by COVID virus, by spike protein, then the macrophage get confused, and instead of polarizing the immune system to cytotoxic T cells to kill the virus, eliminate those cells that's being infected, they polarize into Th17 and sometimes into Th2. So those are things that we need to learn about.
Can I make a comment?
Yeah.
I think I like the idea of, and this is what I realized today, is seeing the chronic infections, grouping them under redox in the context of seeing a new patient. And when you're getting an endothelial test, you realize that a very high oxidative stress score, via the endothelium dysfunction or autonomic dysfunction, will also clue you into chronic infection because of, like you said, they're releasing toxins that are generating the free radicals, or they're free radical generators. It's just, I like the way to organize. I like it how it's organized in my mind to see things through the lens of oxidative stress. That's how.
But they all overlap.
But there are overlap, but
Right.
but I see it as a way of organizing the thinking.
Right, just the thinking and the management and giving you those are
Can
close
I
to it.
just say one more thing?
Yes,
That when you're treating chronic infections, and if you just realize and putting more stress of reducing the oxidative stress, but if you don't empower the immune system, and you will not be able to get rid of infection completely, and you can keep on repairing the redox, but you are not
right.
going to have the good defense mechanism to get rid of the infection. So you while you are treating for the oxidative stress, it is imperative that you empower the immune system. Of course, you are treating for the infection, but infection, you can keep on giving the antibiotics for years together. You're not going to get rid of that infection. You can keep on treating the redox. You're not going to get rid of the infection unless you empower your immune system and do the immunomodulation. And one of the things that you pointed out, that you have to make most of the infection, the Th1 system very strong, downregulate the Th17 and make Th1. And for that, whatever way you want to immunomodulate that system, that's how you do it simultaneously while you are trying to work on the oxidative stress, endothelial dysfunction, antibiotics. But this part, if you don't address, you're never going to get rid of that chronic infection.
Right. So when we manage thing, we actually have to go through all those four things, not
Right.
just so let's say, okay, so we have Lyme disease. Okay, and it's a free radical generator because it's secreting it, so that's part of its cause oxidative stress. But when we manage it, we may need to work on interfering with the metabolism of the bacteria by using those antibiotics. So it's metabolically, we are targeting the chemistry of the bacteria using those antibiotics because they interfere with the metabolism of the bacteria and kills it. That's one mechanism of the bacteria. Antibiotics, some of the antibiotics, like those photosensitizers, like methylene blue, they stick into the Lyme disease, and then I shine a light, generate free radicals, and that will kill. So I will employ everything, including suppressing the Th17 and polarizing the immune system to Th1, because you need to get rid from those cells that's been infected with the bacteria. The intracellular pathogens cannot be get rid from by neutrophils and by antibodies. You really need to have the power of the cytotoxic T cells. So yes, when you go through management, you have to go through all those 4 pillars. Same thing when you're doing anything, but it's just way to simplify things. But definitely when in the management, you need to go through all of it.
What it's not saying, from my understanding, what it's not saying is buffer the redox first. My understanding is it just happens to be the first thing when you're doing an endothelial test. It's if the oxidative stress is high, it's pointing towards chronic infection as part of the differential. It doesn't mean that first you buffer the redox, then you modulate the immune system. Then
you can do it at the same time.
I see this as organizing your thoughts around the patient when you're seeing them for the first time,
Right.
and you're trying to find out what's going on. If this is a way, and you're getting a screening test, which is, first thing for everybody, and then you're seeing these lots of endothelial dysfunction and autonomic dysfunction, automatically you know that we're going to have to get look for chronic pathogens, get like a pathogen profile, lymphocyte map simultaneously. Already the thoughts and your differential is leaning towards chronic infection and the other things that.
But you employ everything that you have: metabolic, redox, immune. Even at the end of the day, if you finish all of this, then you say, well, because of all this damage, I think the patient needs some regeneration. So let's give him some exosomes, or let's give him clotho, oxytocin to regenerate the body. So we need to go through all those 4 pillars, but we need to prioritize and coming up with a plan that sometimes we use same time. Sometimes I don't use exosomes in the beginning. I will let the last thing after I do the metabolism and the immune and redox, and then I go. So it depends on the conditions. I need you to be all open-minded about it.
Maybe, Dr. Patel, not that you are the master, and
Right.
and not to take anything away from what you said. I'm imagining somebody this as being training wheels for somebody who's learning this language to organize their thoughts, to have things separated so they know what, the difference between oxidative stress, the difference between inflammation, the difference between metabolic issues, and know, so that they're not jumping straight to what the amateurs would do, is just give them stem cells.
Right.
If it was everything, and then you're missing the boat, because things are so much more complicated now. It's just multi-toxicity storm inside the body. Nothing fits the old models, and so I just see it as training wheels for somebody who is learning this language. But no, thank you for your comments.
Right, and the overlap is very clear. You can put those circles, those 4 pillars, and overlap them to each other, where they all work together. The other pillar is metabolic. Now, when I say metabolic, people, they think, oh, metabolic syndrome, you're talking about diabetic, hypertension, and lipid. No, I'm talking about all the metabolic reactions, all the biochemistry in the body needs to be optimized. Vitamin D deficiency, 6-hormone, all those genetic SNPs that leads to problem with metabolism of those supplements or vitamins or minerals, anything, including, let's say, big pharma product increasing L-DOPA, right? And I'm using drugs that increase the L-DOPA. That's part of metabolism. Anything that normalizes the chemistry of the body, especially the endogenous product of the body, the chemicals, and normalizing it, then that's considered metabolic. But sometimes those metabolic, like 6 hormones, they have immune modulation effect. And I use it as a metabolic, yes. Let's just say the patient with anti-NMDA receptor encephalopathy, she has inflammation. and the brain. What is the most safest way to reduce inflammation without causing any side effects? Progesterone.
Intranasal progesterone.
Progesterone, and it's metabolic, but I use it here to decrease the inflammation. It's immune. So we need to be open-minded and not to be rigid in those classifications. And
That's like the
right.
more like mastery level, or when you're getting good at this, and it's like you can start with the you know that they have the progesterone deficiency. I mean, you should test for it. But you do realize that there's an epidemic of
Progesterone deficiency
and estrone dominance,
And estrone dominance.
and that the estrone dominance is contributing to the inflammation, and that if you're going to get rid of help modulate the brain inflammation the most effectively, then you want the progesterone to go directly to the brain. And then this idea of combining it with the cyclodextrin, not only is it acting as a particle that is carrying it past the blood-brain barrier easier, but also
it has anti-inflammatory, the cyclodextrin itself.
Okay, and then also at the same time that there's a detoxification effect going on, that as the cyclodextrin is releasing the progesterone and then circulating around the body and removing the fat soluble toxins. I like that way. It's the thinking, and I know that there's literature to back these things up, translated different articles that point towards a similar conclusion.
Again, this article is for everybody here to evolve in editing it, expanding. Dr. Patel, Dr. William, anybody here is interested to expand it, add their spices, their vision, their diagnostic map, their diagnostic road, whatever you want. Those articles are open.
Send
we
me,
can
send
edit
me a
it.
copy of it.
Again.
We'll put it on our website.
Well, I will send you the copy, and I want you to add your flavor if you can, along with Dr. Patel, if you can add your spices and put your name there as well. It makes sense?
You'll remember
We need
a
to
few months ago,
collaborate.
I sent you the hormone handout. It was about 30 pages.
30 pages.
Yeah.
Can you edit it in a way that it will work with this general thing, and then we will create something specific? If you send me that in words,
I sent it to you about 3 months ago.
send it to me in words, not PowerPoint. Can you do that?
It wasn't.
And if you send
It was
me
a
in
PDF.
words,
It was a PDF.
okay, I will try to change because I'm putting it
What
there.
happens when I try to convert it to Word is that all of the columns get all messed up.
That's fine. I need the words. That's it. It doesn't matter if it's being in sequence. I will take it, put it in AI, and command the AI to format it in a publication forums, and with references and with those little link that those numbers, and then I will send it to you, and you tell me what you think about it. Because that's what I did. I put gibberish word there, even not finishing the grammar, and the AI will fix everything and clean everything. The important is the concept, and the concept, and then the editing that you do, and then you go back and you ask to fix this, add this, edit this. It's you commanding the AI, not the AI is commanding you, telling you what it is. And if you do that, and I think we can all work together on this.
Yeah.
So
That's why I have Dr. Burgess. He's the one who tells me what to do.
he's your AI, right?
Yeah. He's my own little private AI.
I should probably start landing the plane a little bit, but I
Okay.
was gonna say, yeah, probably landing the plane here, because it's a lot of information. But I was gonna say, back to this sort of mastery level thinking, once you have the concepts together, it's just when you're when you're doing something, you want it to accomplish a lot of things at once. And that, back to that progesterone example, more for people who are a little bit, maybe over the age of 50, just so you don't get it confused with, women who are menstruating, although there may still be a place for the intranasal progesterone in those situations. But just the thinking, again, when you also realize that progesterone is also activating GABA and reducing anxiety, it's improving sleep, but it's also decreasing sympathetic tone, because there's usually
we learned this from Dr. Bill William. He's the one who tells us progesterone is a GABA.
yeah, exactly. I mean,
I'm just telling the honest truth. I'm surrounded by smart people.
Hey,
Right.
I mean, to put this stuff together, I mean, this is an incredible amount of information, but that's more the mastery level is, we have is what I've learned is being able to accomplish a lot with knowing the mechanisms of action, okay, the mechanisms, what's happening on a cellular level, understanding redox. I mean, I used to think inflammation was everything until I met Dr. Halasa. Then all of a sudden this world of oxidative stress grew bigger and bigger, until I started seeing how oxidative stress was happening on the cellular level, which takes time when you're looking over the articles. But I found that you could accomplish when you start to know that like progesterone, it's handling metabolic, it's also modulating the immune system, it's activating GABA, increased sleep, it's increasing the detoxing of the brain at nighttime. The cyclodextron has anti-inflammatory effects, and by reducing the sympathetic tone, you're also, in a sense, how would you be buffering the redox? There's a redox effect. Is it just simply by modulating the immune system, or is it through
The redox itself?
the redox itself? Where does
Well, there's
redox-
many ways. You can give the antioxidant.
No. I'm saying when progesterone, that example of reducing
Oh, how
neuroinflammation.
progesterone itself. Well, progesterone do inhibit the TH17.
But how is it affect? I'm curious.
It increased the expression of antioxidant enzymes. It improved the endothelial function test.
How? By
It stimulates the expression of antioxidant enzymes. So prostatitis mutase, name them.
intrinsically.
Yes.
Okay,
It's
you guys
not the
have-
cell, it helps with the expression of antioxidants.
Okay.
You guys
Enzymes.
So
have a
that's-
bit of a summary here?
Yeah. Yeah, good.
Yeah, I mean, I'm
Sum up.
almost done. I would just go to a little bit on metabolism and then go to regenerative status and we're done. Give me 15 minutes and we're here. We're done.
Well, okay, go for
5
it.
minutes. Yeah. So basically, when I say metabolic status assessment is not just those metabolic syndrome that we know, which is the diabetic and hypertension and obesity. Every chemical in the body. And I did focus on iodine. And I learned that from Dr. Stefan. And iodine, because something that's been overlooked. Why? Because I think we've been exposed and become toxic with halogens, the fluoride and chlorine and the bromine and all those things, especially the swimming pool. And we have iodine deficiency because those halogens replaced iodine. And iodine, we thought it's only for improving the thyroid function, but it's really, it's more than that. It involved in expression of antioxidants. It also helped in differentiation of the cells, and it inhibit too much of proliferations. So especially if a patient has breast cysts, you give iodine. If they have too much of estrogens, estrone especially, it will counteract it by inhibiting the aromatase. By the way, iodine is a very effective aromatase inhibitor. So when we give progesterone intranasal, we'd like to give iodine as well. And that helps to balance the sex hormone and inhibit too much of estrogens and too much of excessive proliferation of estrogens. And also it it helps to prevent those steroids from moving to cortisone. It actually helps them to stay in the sex hormone and producing those sex hormones. So iodine has many multiple effects, and I'd like everybody to have it at least around 5 to 10 milligram of iodide, not just iodine potassium, which is the cheapest version. Again, it includes also the cholesterol and the high density lipoprotein, especially the oxidized one. And I think from Dr. Nariu, we learned the difference between oxidized LDL and LDL particle, which is number of, and reality is that it's not about an increase in LDL causing the problem of atherosclerosis. It's about the oxidized LDL, and it's about the increase of glucose and rich diet with carbohydrates. High glucose itself can turn to glycan and get oxidized and become free radical generator. And they want to oxidize LDL. And when they oxidize LDL, this will cause oxidation of the components of the blood vessels, especially the endothelium, and lead to atherosclerosis. So that's why I don't think the right thing to do when you have high LDL, it's more controlling the sugar, low carb diet. And I don't think we need to use statin just because the LDL is a little bit high. I think we just need to focus on low carb diet to prevent oxidation of those LDL. So then the sex hormone is part of the metabolic panel, and we need to really come up with a complete panel of sex hormone, including the progesterone, the testosterone, and even the 3 forms of estrogen: estriol, estradiol, estrogens, we really need to report that, because imbalance in the estrogen forms and ratio is the reason why we have estrogen dominant syndrome. And we can manage estrogen dominant syndrome by counteracting the estrogens with progesterone, by inhibiting the aromatase with iodine. I think we can do better if we not just normalizing the range of sex hormone, but also the ratio of the sex hormone. And we have some lab we are working with so that they can come up with forms that helps the doctors to understand the importance of normalizing the ratio. So the hormonal imbalance can affect the metabolic health and definitely can aggravate any chronic disease. It makes you more prone to disease, especially when you have estrogen dominance and you have too much of estrogens, because estrogens are inflammatory. Yes, and they are proliferative as well. And they can lead to, they are the reason why we have prostate cancer, endometrial cancer. They're the reason we have metabolic syndrome. And so patients, we give them testosterone without giving them progesterone iodine. What would happen to this testosterone? Will convert, especially if he has extra weight, by the fat tissue to estrogens, and the estrogens will lead to prostatic cancer. Estrogens will aggravate metabolic syndrome because it's inflammatory. So it's very important to inhibit the aromatase of the testosterone to estrogens, even aromatase of estradiol to estrogens using iodine. Nutritional and genetics, it is very important to know all those genetic SNPs, because you can give vitamin D and the patient has genetic SNPs, they cannot metabolize vitamin D. So this vitamin allowance dose that we know, it's for the healthy people who does not have genetic SNPs. But if patient is sick and has rheumatoid arthritis or psoriasis, they need higher dose, maybe 10 times what the vitamins recommended by the mainstream medicine. So when you're sick, you need to increase it. When you increase your age, you need to increase the dose of the vitamins. And if you have genetic SNPs, you also need to make sure that you're taking enough of that vitamins, because that vitamin is not metabolized well in the body. So nutritional genetics is very important part of metabolic balance.
They're probably gonna need 10 minutes for questions.
The last thing for this, which is we've done the regenerative status, and what's the best thing is to evaluate the Clotho level. There is a diagnostic test for that, and we can give Clotho, or we can do the telomeres, or many ways to assess the regenerative status of the patient, or just by knowing that the patient has inflammation and things like that, and we got the inflammation out, or patient has cancer and we treat the patient with cancer, then we need to consider after that how we can regenerate the body. But I think regeneration has to be the last thing to do after you fix the metabolic immune redox. Then you think about how we can restore the healing and regeneration by giving Clotho, oxytocin, thymosin beta, also interleukin-11. It's a big thing recently. It's a trend because they relate interleukin-11 with fibrosis and inflammation, especially with aging. And we need to find out things that inhibit the interleukin-11. The big pharma came up with antibodies, right? But we can do other better than that. We can do Clotho, we can do the polyphenols. All of those can reduce the level of the interleukin-11. The other part is cancer. Why cancer? I put it under regenerative because it is abnormal regeneration. So that's the reason cancer is under regenerative status. And cancer, we treat it with multiple way. It's I have a problem with doctors will say, oh, just keto diet is enough, or just give them antifungal and it's enough, or give them ivermectin and that. No, those are layers. Cancer is a very intelligent creature, and they have many. You need to work on those many layers. Yes, the low carb diet is good. Ivermectin may be possible to inhibit the Th17 and maybe interfere with the cancer. Some antifungal drugs can inhibit the Th17, interfere with the cancer, but that's not enough. You really need to go and even use photodynamic therapy. You need to do some other immune modulation, polarize the immune system to Th1. You need to do antifibrotic. You need to do antiplatelets. There is many layers for cancer, and we need to understand that the cancer is an intelligent creature, and you're using all the way to evade the immune system, polarize the immune system away from Th1 cytotoxic T cells, and we may need to use also big pharma products, those antibody, anti-CTLA-4, the anti-PD-L1. And so cancer is an intelligent creature, and just a low-carb diet is not going to be enough, or insulin shots that they are giving, which is those hypoglycemic shocks, is not enough. We really need to peel the layers of the cancer to manage it. And we can monitor the efficacy of the treatment using, the best thing is circulating tumor cells. It's more sensitive than the PET scan. And yes, cancer is considered chronic diseases under regenerative. And we can come up with genetic testing that helps us to know whether this patient will have high risk of having cancer. We have a lot of genetic SNPs that can tell us this patient will have cancer. And I think doing it is good, especially with the family members of the patient who have cancer. I have thyroid cancer, pulmonary cancer. My father has it. So you inherit cancer and you inherit money. So it's not just money all the time. And again, treating cancer, it's not a simple way. You really need to know all the tactic of the cancer and address them, knowing what the cancer does. It increases the fibrosis, it squeezes the blood vessels with the fibrosis, preventing lymphocyte infiltration. So you need to give them antifibrosis. It does cause the cancer to be wrapped around platelets. So you need to cover them with antiplatelets, to polarize the immune system away from Th1 into Th2 and Th17. So you need to inhibit that, the Th17 and Th1. You need to work on inducing apoptosis, using photodynamic therapy, using all this method that we learned. You need to change the metabolism of the cancer, low carb and all that stuff we do, but it's many things. It's just not one thing. I think we're done. If there's any questions, I'm open.
Stop share.
37 from 35 to 37. That's not enough. A lot of drop, Doctor. We dropped only. We lost you.
I think we had 44 at our peak.
44 to 37. How many people now? 7?
A lot of our Filipino friends are at their conference, and it's starting almost now.
So I'm good, right?
Yeah,
I still my rate is high, so I can present next time, right?
Yeah. Why?
Yes.
I think one of the things we need is I mean, you put a lot of stuff in there, and what we need is, okay, visit 1. What do we do? Visit 2, what do we do? You can't do all of this all at once. And there's a pretty big expense to a lot of these tests, a lot of this testing. So
right. So based on history and physical exam, you choose the right way to do. But this is just classification of all the diagnosis tools that you have in your hand. But you don't do them all. And that's the candy shop, what they do, and doing it blindly. Based on history physical exam, physical history, you direct what lab you're going to do, and then what treatment needs to be done. So
is there a basic core of tests that you do? You'll do on everybody?
It's all personal. No. I think endothelial function test. That's something I can do to everybody.
Would it be more considered principles then? Principles of chronic disease? It's the principles. It's not the how-to. It's the principles. Because this is not something you can just a guideline you can look at. This is when you're learning, or the thinking process, or learning how to think, or learning the language. Would you say it's more?
Yeah, or it's a diagnostic.
Principles.
It's diagnostic assessment, not clinical assessment of chronic disease. So it's not history and physical exam in the way that it's just more or less the tools that you have for diagnosing a chronic disease, especially the lab part of it. That's what this lecture is all about. But choosing the lab and choosing what you're going to choose, it's really based on the history and physical exam. Now, the question is that, do we have a test that we can do it for everybody to screen? Yes. Endothelial function test. It's like blood pressure and taking the temperature. You can do endothelial function test because it gives you general status of the redox and inflammation of the body and helps you to monitor the patients. So endothelial function test, autonomic nervous system testing, this is generalized. Every integrative doctor have to have the system. I don't care from where you're going to get it. Okay? Yes, I do consult companies about it, but I don't mention any name of it. But I want you to get it because this one needs to be done every patient.
Any names, but
right.
So somebody who is brand new, a regular medical doctor who does a CBC, a chem profile, a lipid profile, and a TSH with maybe a flex to a T4. I mean, that's all they know, right? Where do they start? Where do they go from there?
Well, based on your history and physical exam, will tell you exactly where you move. You don't just go without having the patient's information, and that will guide you what lab you want to do. So tell me about the patients. Me and you, we can figure out what the next lab needs to be done. If the patient has history of exposure to fungus infection, and he has a lot of symptoms that indicate that patient has fungus infection, and by the exam, you can see that there is some sign of fungus infection, then you do mycotoxins and fungal. If the patient has taking drugs or taking narcotics, has oxidative stress, possibly narcotics is causing the problem. Patients is exposed to EMF, which is something I did not add in this lecture, which needs to be done because something we start presenting it on Monday, the EMF toxicity. And a lot of patients, they're getting oxidative stress and their inflammation or whatever condition they have, it's getting worse, whether they have psoriasis or underlying inflammation with EMF, and they become hypersensitive. They don't have enough of antioxidant, anti-inflammatory to compensate the oxidative induced by EMF. So patients being induced by EMF, it needs to be screened out, and then we need to manage that as well. So really, it's all about what's history and physical exam.
Yeah, Dr. Halasa, quick point here. I can't see how you can't include toxins, environmental toxicity, heavy metal testing, something like that, because you're not going to get an optimum healing person when they're full of toxins. And as you said, and as we talked about yesterday,
If the history and physical exam indicate the patient's being exposed to toxins, then you go and do it. You move to that road. We have the tools there, right? We talked about it. So you don't do it, Grant. You don't do it like based on your wish-washy.
No.
Based on the history, physical
Exactly.
exam, based on the basic lab that you do. You can do basic lab, the metabolic lab and all that stuff. Something it's being done routinely because the patient may have diabetic and all that stuff. You want to do hemoglobin A1C because the patient looks, a little bit obese, signs of fatigue and all that stuff. You can start with those basic ones, but it's all directed by the history of physical exam. I don't
exactly.
the kind of shop who say, "Oh, here, you can do the detox," and he didn't take history. No.
That's not what I'm saying. That's not what I'm saying. You know it.
Or can take vitamin D. There is some clinics like that. I swear to God, there is clinics like that because
they don't know what they're doing.
I've been talking to patient, and then one of the patients say, "My father has Alzheimer," and another doctor that he's a famous, he just took him in, give him Myers cocktail, give him a detox, and charge him $14,000. He didn't talk to him, take history, physical exam, nothing.
I'm suggesting you have to do a full environmental exposure analysis. You need to know if patients have been exposed to mold. You need to know if people have gotten new carpet, things like that, to find out where the toxins are coming from. You won't know unless you do a full, complete exam, environmental history.
Right. You have to know everything. Let me add something to you. CDPM group of American Medical Association, they came up with 360 HP. What's the meaning of 360 HP, which I think every doctor needs to be adapting it. When you take the history, it has to be comprehensive, including the toxins exposure.
Yeah, but they don't know what to ask.
Okay, those are the things that we need to, if that's the case, we need to train the doctors to come up with the questionnaires. I have a questionnaires that's being generated by the
I have
AI.
one I will send to you.
I will share you that questionnaire.
Yeah,
I have a questionnaire, yes and no, and it includes the toxins.
Let's do it. I'll send you the one I have. 5 pages.
I have one that's being generated. All those tools that we have, all the things that's comprehensive, and I need people to add more if there's any.
Yeah.
I ask the AI. I tell them I need patient questionnaire based on all those diagnoses.
Well, but we have to get all the way down to
and I have it. And if there's anything missing from that questionnaires, I want you to edit it and add it. How about that?
That's perfect.
Okay, we're good?
We're good.
Okay.
Yeah. Okay. Our Dr. Hallis says that she thinks pretty much everyone is exposed to toxins, women more than men because of cosmetics.
Right, but still, I will do the history.
100%.
All right,
I will do the history.
So let me give you
justify it, so I will not be in trouble with the mainstream medicine or those people, the regulatories, why are you
Oh.
doing this? Why? I will take the history to justify whatever I'm doing. Yes.
We love being in trouble with mainstream medicine. That's why we exist. Come on, stop it. All right, so
Well,
let me ask
they
let me ask,
controversialize it, and I don't think you
let
want
me
to.
let me give
butt
you.
heading.
I know it's getting late, and especially on the East Coast.
It's 8:30. What is late, man? 8:30 now.
It's 10 o'clock in the East Coast.
Oh, I'm seeing it wrong. There's an airdrop here. It's giving me a
Okay.
wrong one. Yeah, it's
But let me
third.
ask you this. I had a lady come in today. I'm going to give you a brief history. I'm not going to go through everything. She's 53 years old. She was complaining of menopausal symptoms with extreme fatigue and hot flashes. Okay. Physical exam was, she was 5'3". She weighed about 170 pounds. Her pressure was 120/60. Her pulse was 82, and respiration 16. She said she wasn't feeling well and she was tired all the time. Okay, go. Well, you gave us.
How old is she? You said, how old is she?
53.
Okay, and she has hot
And
flashes, so
she's an engineer.
she has hot flashes, so you think
she
that
works
she's
for IGT. She engineers slot machines. That's what she does. She's got two children. One is 20 and one is
do you
17.
think in her job there's exposure to the toxins?
I'm not really sure. I asked her. She said that she did work at an aluminum factory at one time.
Oh, that could be a good one.
There you go.
Yeah, and what I will do first of all for this patient, I will check their endothelial function test and score them, and see if they have oxidative stress. That's the first thing I will do.
All right. Well, suppose I don't have an endothelial function test machine.
Well, it's good to have it, so
You know me.
that
I'm too cheap to buy that stuff.
serious if she has oxidative stress. And this gives me a baseline that the patient has oxidative stress. And then I will do the metabolic panels, okay, just to make sure, because I don't know about her history. Has she done metabolic panel before or not, and how
All right.
long
Well,
is
you want that? That I got. You want that?
Okay, I will definitely
I
do
got
her the CBC and differential. Differential gives me indication if there's any underlying infections, anything like that.
Yeah.
I
No,
will do that.
her weight count was 5,200. Her
Okay. What about the differential? Did you did that?
neutrophils, the lymphs were 2-1. They all look pretty good.
So immune seems like it's okay. I don't go far there.
Her
with
blood
cytokine.
sugar, her blood sugar was
Yeah.
83. Her C-reactive protein 1.03. Insulin was 6. Homocysteine was 13.4.
There you go.
And vitamin D
Homocysteine?
was 99.9.
Homocysteine is how much?
What did you ask? Which one?
Homocysteine, how much?
13.4.
Is that normal?
Well, in my book, that's high.
Okay.
Normal.
So she has some sort of maybe SNPs, maybe oxidative stress there. That's caused by, you can see homocysteine is an oxidative stress redox generator or free radical generator.
Okay. What else do you want to know?
6 hormones.
Okay. Her estradiol was less than 5, basically 0. Her estrone was 23, and her progesterone was 0.2.
That's estrogen dominant syndrome. Just by knowing estrogens and estradiol ratio, it's above 2.
Yeah, but she has hot flashes and night sweats, so she has an estrogen.
I will give, yeah, and she's a low. I think part of her problem now, it's 6 hormone needs to be normalized and the ratio needs to normalize. I think she has estrogen dominant syndrome.
Okay. Her testosterone was 15.
Right.
Sex hormone binding globulin was 54.
So do you want to normalize her 6 hormone?
Yeah.
Okay, so that will definitely help to even improve the endothelial function score and her oxidative stress. And a lot of things. She'll feel great after that. If you want to do heavy metals because of the machine and exposure to all those chemicals, you can do the heavy metals and all the toxic thing. This is justify it just because of her work. So 6 hormone with the environmental toxins. Has she has any exposure to think about Lyme infection, thing like that?
I didn't get that out of her, no. I got a few
Okay, so
labs here, though. I got a DHEA of 79 and a
Mhm.
pregnenolone less than 10, basically zero.
so basically, balancing sex hormonal ratio,
Mm-hmm.
doing toxins, what we call screening for her, just because of her exposure in her work, and then I will start managing and see the score is improved or not. And if it does not improve the deuterium function score, there is another source of free radicals that we need to investigate. But we can start with this to make it efficient, effective, and to the next step and see what will
Well,
happen.
you can't always
Do you
jump
think?
to
Do you
conclusions.
think?
She's
I will
good
give
at-
folic acids. I will give make sure folinic acid, not folic acid, folinic acid. They say it's better bypassing any SNPs that's there.
Mhm.
Folinic acid, B12. I will go. CBC was the red blood cells was good. There's no big red blood cells, and all
Her
that stuff.
MC mean corpuscular volume was 91.
Okay,
Okay.
within yeah.
Her IGF-1, so that's our growth hormone screen, was 76.
Right. I will book B complex.
Those of you out
Screen-
there in fantasy land, our goal is usually 200 to 250. That's a screen we use for growth hormone.
You want to that part? I think you are more experienced than me when it comes into the growth hormone.
Well,
So
what I'm trying to get across is, what is somebody like Dr. Burgess who is coming in here cold? What does he do?
he has cold.
No, he's coming in cold. Dr. Burgess doesn't know anything. You know that.
That's right. He's
going to
calling
do
me
color
stupid.
therapy on them, on everybody. You know that.
You know what? And since you mentioned IGF-1, and I know we've made a few references to things that involved Dr. Forsyth, and I haven't heard much about him, and I believe Melvin's taking his place pretty much. Am I right?
Yeah, he is. Yeah, well, Dr. Forsyth's 88 years old. It's time for him to,
Yeah, he's a monster, but
play
he
with
was
his
also,
horses.
but he was an expert on the IGF-1, 10 years and beyond.
Yeah.
So now Melvin does that, and you
Yeah,
do that, Bill.
those of you who don't know, in 2005, he was arrested for allegedly illegally prescribing growth hormone, and
Wait,
Do you think if you normalize the sex hormone, the IGF-1 will normalize as well? I mean, can you give a chance for doing the basic things and let that go, and then figure out the other ones?
All right, let me give you a couple
You
of
wanna do
other,
that one?
a little bit more information on her. She has been on a gluten-free, dairy-free, and sugar-free diet for 20 years because she says it makes her ill, which is
good, right?
which is good, right? Her TSH
Right,
was
yeah.
1.79 and her free T3 was 3.1. And
TSH, how much?
what was that?
The TSH, how much?
1.79.
Okay, that's okay.
Yeah, and free T3 is
That's fine.
3.1, which is, a normal sort of mid range. And her
Before,
reverse T3 was 19.5.
is that high?
Yeah. Yeah. So
Yeah, if
And
reverse
this-
T3 is
Here's the
high,
thing, I will not give thyroid for those T3. This is oxidative stress that she has from low sex hormone and possibly from toxins we need to figure out. Once you improve the anti-redox balance, her the enzyme that's responsible for conversion, the T4 to T3, I think that would normalize and her thyroid will be okay.
well, what
So
else?
I would not.
What else do you need to know? I have a little more information, so I might.
Okay, go. I mean, whatever you have, it's good. You want me to ask what lab you want me to do with this patient?
Well, in your hierarchy, where do you go from here?
I will start treating the patient, normalizing her sex hormone, checking her if she has any heavy metals exposure and toxins. I'll go with that, and I will give her folinic acid and B12 complex and all that, and then I will see what's going on. I would not do everything at once because normalizing sex hormone can normalize a lot of things out there.
So wait, are you saying that everybody who walks in the door, you're going to do an endothelial, whatever?
Yes. Yes, and the DA function test for
And what does it-
everybody to
and
school.
then what does it tell us?
It tells us that this patient's oxidative status, redox status, an inflammatory status. And when I start doing the 6-hormone or detoxing the body or whatever intervention I see, I can see that the score goes up. And that's mean my treatment is working. If it does not go up, that's mean there's some other holes that
Well,
source of free radicals that I
don't these patients tell you if they're not getting better?
That's subjectively, yes, but it's good to have something that objectively showing that the endothelium is improved by my treatment.
All right. So
Right.
what haven't you done in the initial workup that you should have done? And she gave you a hint or a clue that what should have done.
What I should have done with her,
Yep.
besides normalizing her 6-hormone and seeing her toxins
Mhm.
and giving her B complex.
Mhm.
Endothelial function test and autonomic nervous system, that's one pack there.
Right.
I don't know what do you want to add?
Well, she gave you a hint. She told you that she was on a gluten-free diet for 20 years because gluten made her sick. I don't know about your
Well,
patients,
again,
but my patients
not
aren't that aware.
necessarily. Yeah, do you think that she has gluten sensitivity and celiac disease of those patients? Not
Well, I don't
necessarily
know.
that.
Like I said, this was the first time she came in.
Right. So if you think that is the case, because some people they're
Well-
doing it just for the health.
Right.
So I want to make sure in her past history she's being diagnosed with celiac disease or not.
If we do a gliadin antibody and it's negative, we're going to tell her it's okay for her to eat gluten then?
If she is antibodies is negative,
If the gluten antibodies
you know
are
what?
negative,
I'll tell you something that I know. If patients is away from gluten for a long period of time, regardless of whether they have celiac disease or not, if you give them gluten, they will react to it and they will have a problem,
Mhm.
regardless if she has celiac disease or not.
What's the
Well,
problem
yeah,
with
right,
this?
of course.
You got my point?
Yeah, of course.
My wife,
It was like,
she stopped drinking
remember
milk.
when we went from whole milk to 2% milk because we were supposed to be on a low fat diet, and then we went to 1%, and then right. Then what did it taste like when you went back to the whole milk again because you were in the hospital and they only had whole milk? That's right.
You know what happened? I'll tell you what happened. My wife, she said hear about inflammation of the milk, so she stopped taking milk, right?
Mm-hmm.
After 1 year of stopping taking milk, and she used to drink milk, no problem. Now if she takes any milk, she's having bloating. You got my point?
Yep. Mm-hmm.
So people, if you stop taking something, you may end up becoming sensitive to it as well, if you take it back. It may take a little bit of a process for them to go back to the milk.
Mm-hmm.
But I'm just saying, even if they are low, not taking gluten, all that stuff, I would not, even if she is celiac disease negative, and we have all the investigation for that you can do,
You still
I will not.
right. You still miss the elephant in the room, though.
Well, let's learn from you, man. I'm
Okay.
open.
What are her thyroid antibodies?
Okay, that's a good one. If you said that her thyroid function was
normal
within the norm,
Yeah, it's normal.
right?
Yeah.
Yeah, if you expect that there is anti-thyroid because of the
Why would
possibly
why would I
disease.
expect the reason I would
Because
expect is because if she
people
can't
with
tolerate
autoimmune
gluten-
disease, if you expect patient has celiac disease, they also have thyroiditis.
Mhm.
They
Well,
also have
her
antibodies.
TPO was greater than 600 and her thyroid antiglobulin was 3.6.
So it's 3.6. That's high, right?
It's very high. Yeah.
Right. So that's means she is in the
So
edge of
this
Hashimoto's thyroid.
this lady's had thyroid issues for over 20 years and nobody checked her thyroid antibodies.
Did she take? Well, the thyroid you said is almost normal, except the T3, right?
T3 was
The T4, how much is it?
1.54.
The T4.
The T4.
Same like the E3 issue?
Oh,
T3 is 3.1.
T4 is low, right?
T4 is no, that's actually on the higher end.
How much?
1.54.
1 point. Okay, so above 1. Yeah, 0.1 to 1. Yeah.
We're having to check.
So
for
she
reverse
is
T3.
it good because of that the thyroid thing. she is starting having Hashimoto thyroiditis, but it's not
She's probably
manifested.
had it for 20 years. So this is what I did. So again, we went over the gluten-free diet, which she already knew. So we did, so there's lots of ways to go. So we did start her on
Naltrexone,
hormones.
NAD.
We gave her
Yeah.
estradiol patch, 0.0375 twice a week. Progesterone pills, 200 milligrams. And remember, not progestins, progesterone. And then we gave her testosterone, 20 milligrams IM weekly. So that's
Cool.
That's our hormone.
That will help the inflammation, by the way, if she has Hashimoto thyroiditis.
She was on, I didn't tell you, she was on 10,000 units of vitamin D3 a day. So we cut that back to 5,000. She was 99.9. She was taking probiotics. So we gave her, I don't know if you know what it is, Secretropin spray. It's from Dr. Gordon's sort of homeopathic formula to raise IGF-1. It usually raises it about 25%. She didn't want any injections. We use plant sterolins. Magicare is the one I like. Plant sterolins are they act like Pac-Man, and they actually phagocytize thyroid antibodies. They on average will decrease your thyroid load, TPO thyroid antibody load by about 50% in a year. So she's greater than 600. She could be, remember I told you at one time I had one patient where they counted it all out. It was 4,226. That's my world record. So this will take
You can give this patient naltrexone. She's on it or no?
No. I'll tell you what I told her about naltrexone in a minute. We gave her DHEA and pregnenolone because those were low.
Yeah.
And her memory was kind of shot. And then we gave her an adaptogenic herb also. The main ingredients are ashwagandha, rhodiola, and cordyceps. You don't like that one? You making a face?
No. I'm good.
Okay. And then we gave her some berberine. Oh, her cholesterol was a little high also. We gave her some berberine for that. Okay. So that was what I did. And
I think I will, if her antibody is Hashimoto thing, I will give her naltrexone for that. But I will not give any.
I usually unless they're and she's actually one. What I do is I send them home with or I email them my paper on low dose naltrexone, and I also always tell them to look it up on their own because I don't want them. I want them to look at what somebody else says, not what I write. So get somebody else's perspective on it. And a lot of times, what I tell them is, in the hour that you're here or hour and a half, I'm not going to be able to know every aspect of your being. And if you ever look at the symptoms of hypothyroid or thyroid, even hyperthyroidism, there's 400 of them.
Right.
So I asked them to go
But
look
she's
it up
not
on their own
many.
and
You
see if-
cannot call her hypothyroid, right?
look it up on their own and see if it matches, a lot of the symptoms that they present with.
She's
Frequently
compensated,
what
but
they'll
not
do is
that
I'll get a
much.
call tomorrow morning saying, yeah, this sounds like me. If I don't, I ride with the what I showed you. I usually will redo the thyroid antibodies in about 8 to 12 weeks. And if we're not getting anywhere, then we'll add the naltrexone.
Right, but I will not give thyroxine for this patient.
No. Her thyroid function is actually quite good.
Right.
The endocrinologist, that's all they have. They'll say, here, you got to take Synthroid. That's it. There's nothing else you can do. And the
That's the
diet doesn't
problem,
matter.
because
And
that will lead to more oxidative stress by increasing the sympathetic and more inflammation and more damaging and more autoimmune and more damaging for the thyroid. And then, yes, then they will need thyroid.
So my challenge to you is I gave you a specific set of circumstances. What do you propose we do for this person?
I will not do anything except the things that you did already. Right.
Right.
And I will observe the effect of it, because everything can be normalized by those things that you did, especially the normalizing the
Yeah,
six
but,
hormone.
we
Now,
have Dr.
toxin-
Burgess here, and he's lost. He doesn't
the
know.
toxin, the heavy metals of the toxins, I mean, work, maybe you want to do that screening if you want.
Right.
You want to check if she's been exposed to the EMF, something that's being overlooked.
Yeah.
That's something you may need to consult with her because that can aggravate the inflammation. But again, industrial function test will be done before you do all this treatment, so you can know your treatment is working or not objectively instead of subjectively. And I will let the patients, I will absorb the effect of all of this and come up with the follow-up.
Okay. There's a lot of questions and comments in the chat. I don't know if you want to go over any of those.
Yeah, go ahead, man. They still have time.
Okay. So way back at 5:12 our time, which is 3 hours earlier than where you are. Let me find it. There was a comment about there was a comment about HUMAP test for metabolism, metabolites. You know anything about that? That was from Steve
is that?
Hopper. I don't know if he's still on. It looks like he's still on. HUMAP test, HUMAP. So, we've used the organic oats test, and it's very complicated. I mean, they use all sorts of crazy language, and it takes 2 to 3 hours. It takes me 3 hours to try and interpret it. I don't want to deal with that. You got to figure out what the language they're using and then interpret it into English. So, I'll give you an example. One that I know is kinuretic acid. They'll measure that, and that's B12 folic acid. But there's, it's 30 pages of that.
I will give folinic acid. That's part of the thing we talked about, right? Say because of her homocysteine high, I'll give her folic acid. Folinic acid better than folic acid. The folinic. I learned that folinic is better. If they have genetic SNPs, you can bypass it.
Okay.
Or antibodies against the folinic acid receptors.
Okay.
Whatever.
Dr. Bill,
Yeah.
UMAP is actually a urinary test. It's almost equivalent to Dutch testing.
Okay.
So,
I don't know. I know from nothing. So I know what the Dutch test.
Yeah, it's
Okay. Well, good.
Yes, doctors. Yeah.
Okay. Don't you have a performance to get ready for?
I know.
Don't you have to when I give a talk, I need 3 hours to get ready. You're young, I guess.
He has it all right now.
Dr. Quinn mentioned something about curcumin. I'm not sure what the context was. It was after the endothelial function testing discussion.
He was asking about some anti-inflammatory that was yellow.
Yeah, that would be curcumin, right?
That's a guess.
Yeah.
Curcumin.
So,
You can give that as an
rapeseed and bicillin. Okay. Dr. Burgess is looking for some volunteers for his research committee. John, why don't you put your email address in the chat there?
I'll do it. Thank you.
jb@jb5.com, but I can't ever remember it. Okay, and Dr. Halasa has lots of questions. Chelation, psychodextrone. I don't know what that is.
cyclodextrin, yes.
Okay, yeah, she spelled it PSY. It's CYCLODEXTRINE. Okay, so okay. She asks about activated charcoal. Again, cyclodextrin, and how to get rid of toxins. So
yeah, cyclodextrin will be one of the good things for fat soluble toxin. It does work also for spike protein and mycotoxins as well. You can still do ADTA and activated charcoal and steolite, but for fat soluble toxins, there's nothing that works except right.
Yeah, and as far as the spike protein, Dr. McCarran, I'm on his email list. He had a great article overnight last night. I sent it to you, Dr. Halasa, about the spike protein and myocarditis and how to diagnose it and how to treat it. Maybe we can go over that in the future.
Well, again, cyclodextrin, I send a text with him. He's very impressed about it. And there's articles about cyclodextrin loading the spike proteins. He's using what's the thrombokinase? to break the spike protein, I'm using cyclodextrin to just get it absorbed and get it out by dumping it through the bile.
Another question,
But you can
how to flush out toxins from fat storages? They mentioned
we talked about
spreading, diet,
cyclodextrin.
cyclodextrin.
Right.
Okay. The problem with cyclodextrin is a very, by itself is, Dr. Klatz's cyclodextrin is really expensive. I mean, it's $250 a month.
Well, we have now loaded inside progesterone, oxytocin. It's included in all those drugs. I think that would be enough to do both, deliver drug and detox the body.
Okay.
So you can get it cheap by having compounding pharmacy formulate your 600 cyclodextrin.
And again, Dr. Hallis, I got the guessing that we're talking about my patient that I just printed. He needs B12, vitamin A, and vitamin D. Okay, well, we pretty much covered that. And Dr. Quinn says that depending on which toxins are present, it will guide you how to detoxify. Test for pesticides, VOCs. I'm not sure what that is. Glyphosate can sometimes tell you what they're present, but treatment is similar for most chemical toxins. Heavy metal detox, EDTA, DMSA, DMPS. What's VOCs, Dr. Quinn?
That's volatile organic compounds you get from paints and things like that.
Okay.
It's fat soluble cyclodextrin.
You get it. You get it from new carpet. You get it from the mastic that sticks carpet and tile down. You get VOCs from everywhere.
How about that new car smell that we always liked when we were kids?
Yeah. Yeah, that is the best smell going, but it's kind of toxic.
Yeah. Yeah, a lot of those things were. And Dr. Dell mentions probably a non-methylizer, the patient that I talked about, that homocysteine is high.
Yes. Methylcobalamin methylation needs to be taken care of because of homocysteine is high. That's why we add methylcobalamin plus folinic acid.
Okay. Dr. Hopper mentions a 10-time methylation test, but it's pricey.
That's right. But you can just start with a methylcobalamin and see what will happen with homocysteine after 3 months.
What about it just
Dr.
a
Halasa, for that methylation, you don't give only the methylcobalamin. It's a combination of all four things you have to give. It's the pyridoxal 5-phosphate, folinic acid, MB12, and betaine hydrochloride. And you have to give all these four in order to lower the homocysteine. And there is one good product protocol has, which is called Methyl Action. And it has all four things.
Can you repeat it again? B12, methylcobalamin, and folinic acid, and what else?
I'm sorry, what?
You said methylcobalamin, folinic acid, and magnesium?
No, folinic acid, pyridoxal 5-phosphate, and betaine hydrochloride.
Hydrochloride, okay.
And there is a preparation called Methyl Action, which is like $20, and that lasts for about 6 weeks. You give that for 3 months, and then you do another label. Most of the time, unless it is in 18 and 20, if it is like in a 15, 16 range, it will come back to normal.
Okay.
And then you continue at a lower dose. And
Do you
then
know why we add those other two ingredients? Do you know what they do?
quinolic acid or kynuric acid is high. Those are the inflammatory markers, and B6 is also required when it is high.
So B complex will cover everything?
No, it requires a higher amount of B. Pyridoxal 5-phosphate is the active phosphorylated form of B6. And
Okay.
that's why sometimes you have to use the activated form. And if you are using B complex, you also have to use the activated B complex, which is phosphorylated. And it works much better in correcting those abnormalities.
Thank you very much for that. Any other questions? I've been grilled today.
That
Dr.
is the side
uh,
effects of
Bill.
cyclodextrin.
You did good.
Okay, I feel
Okay.
the burn.
Okay. Again, Dr. Hopper mentions TMG for homocysteine also. And
That TMG, what I said, betaine hydrochloride. Okay.
right, trimethylglycine. And
Yeah.
the other thing is selenium has a pretty good track record with thyroid antibodies, also 200 micrograms. We get can get up
Yes.
to 40% decrease just using selenium in about 12 months.
Especially if you're using iodide, because this patient possibly is iodide deficiency, something you need to consider that. And also it helps in estrogen dominancy.
Yeah.
But if you give iodide, give selenium with it because it does protect the thyroid from the extra iodine.
I'm still unclear with the autoimmune diseases. If the iodine is you need to be careful with that.
I think with selenium, you're okay. So
Okay.
as long as you add selenium, it would be more peace of mind.
Is Stefan still on, or is he gone? He's our.
No, I agree. Load them with selenium first if you're worried. Give them 300 micrograms, give them 300 micrograms selenium for 3 months, and then you can start the iodine if you're worried about it. But if you give them selenium, they should be fine.
Yes.
Okay. Okay. Anybody else have any comments or questions? This was quite a marathon. So
It's quite of a grilling,
yeah. So
which I
next week,
enjoy it.
next week we have Dr. John Neustat's coming back. Remember he talked to us about osteoporosis a few weeks ago, a couple months ago. He's going to sort of expand on that, and he's going to. I know we've had a few lectures on the microbiome, but he's going to give us his perspective on that also. So that's next week, and in the week after that, we have. I got Lisa Talati. Now, Lisa is our influencer from New Zealand. She's a podcaster there. She's an expert in hyperbaric oxygen. She was a marathon runner, and she's quite the gal. She interviewed me. I'm on her podcast, and we had a grand time. And she's been in our audience a few times. And then the week after that is September 3rd, and we got Heather Halasa, who's joined us tonight and is stuck to it, stuck in there. So thank you so much. And we're going to hear about her what she's been up to. Okay. 10 p.m. Pacific, which is 1 a.m. Eastern time. Dr. Nario's Philippine Alternative Medicine Conference is live streamed on YouTube. Just type in Prima Phil, PRIMAPHIL, and that'll get you to the link on Facebook.
Dr. Bill, Facebook Live.
On Facebook Live, okay? Did I get it right?
Yes.
Okay. Okay, so if you're interested.
How many people left now? 10:30.
What's that?
How many people left at 10:30?
26.
Okay, that's 50%.
Steve was asking for a link, and I'm not sure what link he was asking for. Oh, that might be it.
Okay. Yeah. So the link, just go Facebook Live, Prima Phil, PRIMAPHIL.
That's good.
Okay.
We start with
And that'll get you there. So our own Dr. Nario is the star of the show. So if you can't sleep tonight, give him a ring, or just put it on and put it on mute like I do a lot. So that's okay. This is the third time my internet went out. So